It's past the hour. I'm going to go ahead and get started. Welcome to today's GaPQC webinar for ONN. There you go. I'm on camera. Today's session is going to be over helping families reach their feeding goals. It's everybody's job. I will pass it over to Claire in just a moment, but just some quick updates. The quarterly reports have already been uploaded and has been sent to the data leads. Any of the sites that are looking at it, if you see anything missing from your monthly reports, just let me know. You can always reach out to me. I can put my email into the chat. I can always reopen a survey month for you as needed. We would also like to thank everyone for more than a year of engagement in the Learning Collaborative. So thank you so much. And those within the Active Learning Collaborative, we now have a year's worth of data collection. So yay as a data person. So I'm really happy to hear and see that. Claire, I'm going to go ahead and pass it over to you to present our presenters today.
Thank you, Linda. I want to make sure we have Amanda here. Amanda, are you here?
Hey, Claire, I'm here.
Yes, wonderful. Let me share my screen and I will introduce our topic today. Hi, everyone. Most of you know me, but I'm Claire Eden. I am with the EPIC Breastfeeding Program at the Georgia Chapter AAP. All right, let's make sure. All right, does that look right? Because once I have it going, I can't see you guys or the chat anymore.
It looks great, Claire.
Good. Okay, moving on. I am very pleased to introduce our panel today. Unfortunately, Dr. Pulliam had an emergency at his practice. And so Dr. Fairley will be filling in for him. But I have today Amanda Love, who is a enthusiastic member of this collaborative. She is a nurse and a lactation consultant at Northside Fayette. No, gosh, I cannot see my notes, and I'm sorry. I forgot that when I'm screen sharing.
I think that's Northside Forsyth, right?
Forsyth is where I'm trying to get. Thank you, Northside Forsyth. And she is a clinical specialist. Let's see, clinical development specialist at Northside Forsyth, and moderates and facilitates their breastfeeding committee and task force. And then, of course, many of you know Dr. Taryn Fairley, who is part of our work, really integral to our work here at the Georgia Perinatal Quality Collaborative as subject matter expertise and leadership on the neonatal side of our collaborative. And today our topic is on helping families reach their feeding goals. It's everybody's job. And I'm going to hand it over to Dr. Fairley.
Hi, good afternoon. Hopefully everybody can hear me. If not, please put it in the chat. Today we're going to try and pull some of the big things together that we've been talking about over the past year. A lot of the skill development and background knowledge on NUT, on feeding methods, on skin-to-skin care, all of that. We're going to try and fit all of that together in with our family's feeding goals and figure out where exactly all these pieces come together to get people to their goals. Next slide. So, it's kind of good to address and be very frank and upfront about what our usual state of affairs is, right? What's business as usual in our hospitals? And I think for a lot of hospitals, I know anytime somebody says the word lactation, a lactation consultant turns their head and perks up their ears because by and large, that buck is being tossed in their direction. But there's a lactation-related concern, or if lactation support is needed, that's usually the job of the lactation consultant. Support from other baby nurses varies. Even those who are interested often find ratios are challenging. And even if you want to help at the bedside, that that may just be very difficult with your assignment. I mean, everybody wants a bottle feeding meal tip, right? Like that's usually what people kind of want to see when they come in for their shift. And if everybody else is punting to lactation, by and large, you probably are going to occasionally too. Next slide. So what are we actually trying to accomplish here? Now, this is not NICU specific. I'm talking about mother baby. I'm talking about the vast majority of our term healthy infants born in this country, born in our state. What is it that we're trying to accomplish with our, not quite drive through, but our very brief maternity stays, if you compare to what we used to do 10, 15, 20 years ago? I think people stayed longer in house for good or for ill, right? Well, I mean, we are there to watch their vital signs, to watch their weight, make sure all of those things are stable as they go through some enormous physiologic transitions on both parent and infant side, right? There to manage any medical problems we know about and to monitor for any that might randomly come up. And we're very comfortable with these first two, right? Like this is something, at least on my side of things as a provider, that I'm very comfy with. I'm like, yes, this is what we're doing. We're making sure everything is safe. And then we kind of pay a little bit less attention to these other two big goals. I mean, we only have four real big goals when they're in house with us, right? So teaching, parents and making sure parents are ready for basic infant care is another major goal of the hospitalization. And most of that, honestly, still focuses on feeding, sleeping to some extent, right? Safe sleep is very important. Let's not underemphasize that. But realistically, a lot of it does focus on feeding. And the other big goal is to feed adequately for gestational age and size. So, like a good half of what we're trying to accomplish here is about feeding, but yet we punt feeding to lactation consultants for whom we don't really have nearly as many as we probably need to do that work if that's really the lift that they're expected to make right in the hospital setting. So this is why it really has to be everyone's job. This is about 50% of the work for each dyad, and we don't nearly have enough people to make it their sole job. Next slide.
Okay, so let's take a look at a case study, kind of setting the stage for something that we see often in most of our settings. Next slide, please. All right, so we've got Jennifer and Johnny. So Johnny was actually already known at their hospital even prior to delivery because there was a NEO alert. The sweet baby had a congenital cystic adenomatoid malformation, or a CCAM. So they already had the NEO alert on this kiddo. Mom, Miss Jennifer, was admitted to the hospital for gestational hypertension at 37 weeks. Ended up being induced because her hypertension got worse. So she went on to develop preeclampsia with severe features. She was lucky enough to have a consult with a NEO while she was still on the antenatal unit. And they really didn't think that Johnny was going to need much help. It was a small CCAM that they saw on the screen, but they would come to delivery just to make sure. And the NEO told her the best thing that she could do either way was to give Johnny all the breast milk that she could. Mom agreed and told them that she definitely was planning to breastfeed her baby. Next slide. Okay. Sorry, my screen's behind, Claire. Okay, there we go. So mom
Is that the right
ended up
one?
being,
Sorry.
yes, it's just
Okay.
a little delayed on my end. It's okay.
Yeah.
So, mom had 2 days of monitoring for her hypertension and then ultimately started on a cytotec and pit induction. And during that time frame, she talked with the labor and delivery staff, talked about her birth plan, talked about how she was going to feed Johnny, and she shared that she would like to breastfeed. Her labor and delivery nurse reminded her, we need to make sure Johnny's doing well, but that she would be able to nurse her baby soon after delivery. Next slide. Okay. So D cells started, unfortunately, as the Pitocin was increased, and her preeclampsia obviously worsened with those severe features. She had a headache, her BPs were quite high, receiving medication for that. So the decision was made to do a C-section. Oh, are y'all getting that feedback?
Yeah, if you just joined, if you can make sure you're muted. And thank you.
Okay,
Linda,
there
maybe
we go.
if you could watch that folks get muted. Thanks.
Okay. So after about 3.5 days in the hospital, everyone's ready to meet Johnny, but maybe baby Johnny isn't so ready to be here. So baby Johnny ends up needing some respiratory assistance at delivery. Based on that NEO alert and the respiratory distress, they decided to go ahead and head on to transition and maybe admit to NICU, but we'll see, see how things go. So we've kind of heard that saying that, NICU is where breastfeeding might go to die. Unfortunately, we just miss out on some of those opportunities and it's a separation. So, how's this supported? So Johnny's been admitted, hopefully just for a quick minute. But what happened in that time frame? What goes wrong? How could we support things? Next slide, please. So let's talk about, Jennifer's experience first. So she meets Johnny, she kisses Johnny, then Johnny's taken to transition. Mom's super shaky from the C-section and all that she's just experienced, still has a headache. And she's actually encouraged to rest in PACU. Because of her status, she ends up going to the high-risk unit. She receives MAG, and she just feels awful. They bring a breast pump to the room, but no one's really taught her how to use it so that she can just rest. Postpartum, as she's moving through, she's feeling better. Lactation does come see her the next day, and they get her pumping for the first time, but nothing comes out, and she panics. Her nurse ends up taking her over to visit baby Johnny at this point, and she holds Johnny for the first time, sees all these tubes and monitors, and she is crying and wheeled back to her unit. Next slide. Okay, so what's NICU's perspective here? What's happening to baby Johnny? For the NICU staff, they believed that Jennifer was ill and she had not had a chance to hand express or pump. Johnny needed to be fed. There was an order there for the PO ad lib feed. So he ended up being fed 30 plus mLs on day 1 of life. And on into day 2, ended up having some symptoms of GERD. So the formula was switched to sensitive. When mom finally is able to come and visit again, she is encouraged to start pumping. She obviously feels better and bring milk when she can. Next slide. Postpartum day 3, everyone feels much better, and Jennifer is ready to go home. Now she's at this point taking morphine for her cesarean incision pain. She's on labetalol, PO, all her mags done. She's getting some volume now. We're seeing 10 to 12 mLs when she pumps, and she's happy about that. Things seem to be happening. She wants to go home and breastfeed more, but she's concerned about the meds and Johnny's formula that he's been receiving. Her postpartum nurse, she talks to her about it, and she tells her she needs to ask her pediatrician when she sees one and discharges mom over to the NICU so she can hopefully get Johnny discharged and home. Next slide. Okay, so Johnny did excellent in the NICU. His CCAM is quite small. It's not too bad. And although he will still need to see a pulmonologist and possibly a surgeon later on, he's doing well. So Jennifer's told to get all of those referrals done, get to that pediatrician ASAP. They're definitely educating her about his condition. And then Johnny had bottled huge volumes after switching to the formula, on that sensitive formula. And, they explained to her that it was much better for him. He was doing much better. And no one really wanted to change that because he was doing well, and they were ready to get him home. So he actually never ended up with mom's milk in the hospital. They encouraged her to take it home and use it when she went home. Next slide.
Right. So what's the matter here? Well, I think a lot of us are kind of racking up our mental list of all the different things that might be a matter here. But, as the first step in root cause analysis when you're looking at a situation is to figure out what are the actual problems. And, they're Leviathan here. Like we have lots of different issues related to how the team is working together, to be honest. Like, you've got a provider coming in, a doc coming in saying, we want the milk, please get us the milk, where's the milk? Like when you deliver, where's the milk? Please breastfeed or pump, basically, but no further instruction. And gosh, I have the bias of usually being only on the postpartum end of things, but one does have to wonder, when is somebody more receptive? Prior to delivery, when they're no longer when they're not quite as exhausted as they're going to be, or after delivery when they're sleep deprived, exhausted, and in this case possibly sick. And those hours of induction are kind of a good time to do some learning. Honestly, there's not a lot else while you're waiting for that cytotech to do its job sometimes. So, we didn't really give her any instruction or anything to work on, any kind of preparation beforehand. We had a late start and then some pretty infrequent removal. Milk wasn't treated as a critical resource. It was kind of like, well, if everything else is okay, it's the vitamins approach to breastfeeding. I think a lot of us have heard this throughout the years, done this 18 years, and it's usually treated as like, well, look, if everything's fine, we can do this. And realistically, it's like, I need to make everything okay so that you get this. This is a vital, normal resource for infants. This is how we feed babies. We also overfed. We didn't respect the physiology, developed a feeding intolerance, to probably misdiagnosis of the SCIRD. I don't know if it's SCIRD or we just made you chug Thanksgiving and, Thanksgiving dinner and leftovers all in one go. The NICU bedside milieu, we didn't give a lot of details on it, but it didn't sound like they were ready for her to be with her infant or to maybe even set up some time to pump at bedside or do other things. It wasn't really responsive to lactation in that moment. And, from my perspective as a primarily outpatient doc, I think what's glaring here is that there's no discharge follow-up and no referral for feeding. And my enterprise in KP and Kaiser, a patient with early separation like this receives an intake and close follow-up the first week of life to make sure that feeding goals are met, because it's so often an interrupting factor. Next slide. Amanda?
Great. So what is the role of the nurse? There's going to be a lot of different nurses that come into contact with this family. But right from the get-go, helping to identify the family's plan. What is your plan in the hospital? And when you go home with this baby, getting an idea of what they already know about infant nutrition, and then filling in those educational gaps in a way that they can understand, providing education to them, in that current state. So just like Dr. Fairley said, in labor and delivery, it's a bit calmer. If we're truly going through that induction stage or even an antepartum, maybe you could provide an antepartum consult with a lactation consultant or a CBC, or use your resources, hands-on demonstrations, video clips, handouts, discussion. And no matter where you are in the process of providing the education, using the topic of hand expression and the importance of skin to skin is always a great jumping off point. And it's a great way to help the family, whether the couplet's together or separated, when it comes to hand expression. And then using those touch point opportunities as times to assist, not just once, but throughout the shifts that you're there, and really praising the drops and bringing attention to the small volume that's expected and normal. And then going from there, making sure, does the family know what to do with the milk? Do we know how to store it properly? Do we know how to get it to wherever the baby is? Do we have containers at the bedside? The role of the nurse is really helping to remove those barriers. So figuring out what barriers there are and then trying to address them. And one big one, what if no one's there with mom? Who can she call? How long can that breast milk sit, and things of that nature. And then when we're thinking about the NICU staff, assisting mom with skin to skin right off, you already do such a great job of this, I'm sure, but really trying to help her already start thinking about, there's all these tubes. What is it going to look like when I'm able to start breastfeeding? What's it going to look like when I'm here visiting? And trying to assist with breastfeeding each visit if you're able. Really pointing out feeding cues is another opportunity. Trying to help the family identify what feeding cues, kind of teaching them to answer the hunger call early, and making sure that they have access to the pump at the bedside if baby's not yet PO feeding. That can be a huge help. Next slide. Sorry, there's that lag again. Okay. What does lactation support look like? It's going to look different depending on how it's structured in your facility. Hospitals are going to use lactation consultants in different ways. So it might be one consultant, it might be a whole team, and it can be someone who's more in a CBC type role, or it could be someone who's already at that expert, level. So when the lactation team is there, they're helping everyone. Um, it could be someone who plays another role. It could be someone who's a nurse or a tech, or has another function in the unit, but is also designated as lactation support. So it could just be something that this person does periodically, not every single shift they're here. Could also be nurses who are trained as lactation counselors, breastfeeding educators, lots of different titles there. But you have the skills and the knowledge to manage the standard education, the needs of every patient, on the floor. Maybe not quite those who need that extra assistance or the infant separation, but you could generally help any couplet there on the floor, helping teach them basic latch-on skills, identifying what's the feeding plan, and then identifying when there's a problem. But there might be other models where consultants are required to have extensive lactation training. So, these are your IBCLCs who passed exams and have those additional certifications, and are going to see patients for more specialized needs, those risk identified needs. And so this could be seeing multiples, this could be seeing NICU patients, this could be also outpatient support, but those with anatomical anomalies, different types of endocrine issues. And you, as an IBCLC, are looking at the history of the family, the mom, the infant. You're performing the feeding assessments, and you're truly creating that plan and working with the nursing staff and the providers to come up with these things. Hospitals that use their lactation team more as a generalist, you may need to have more broader or a larger lactation staff. So, this might be where you have many staff trained as CBCs, but only have a few IBCLCs. So all of your staff are able to help the patients. And then when needs are identified, calling in that one IBCLC that might be there on that shift. And then, hospitals that use lactation consultants as experts, they're typically going to need the fewer IBCLCs, but need to make sure that their staff have that broad understanding. And then some hospitals, you fit somewhere in the middle. What you want to really avoid are hospitals that have few lactation consultant positions, but expect lactation to see every single couplet. That's just not feasible. But then there's also hospitals that expect folks with very little training to serve as the expert, and that's not okay either. So the idea there is to find that balance. And for most birthing hospitals, it's going to be for all staff to have a basic knowledge and level of training and act as that generalist, but then to also have specialized staff there from a lactation department standpoint to provide the expert care. So in the slides, you'll have a couple of different staffing guidelines and recommendations. So, you have A1 here in the first slide, and talking about having the lactation consultants every day of the week to assist for those more complex issues. Looking at a smaller FTE ratio for well newborns, and then having the higher FTE ratio when you have those NICU settings with the higher volume of NICU babies. Next slide. And then you also have the AAP levels of care that can be a resource to look at for guidelines as well. And there's just a little bit of a disagreement there when you compare these to the A1 guidelines, really focusing in on your NICU patients. But overall, you should be able to identify, based on the volume of patients that you have, the acuity of your patients, a general idea of what your setting would need. Next slide. And remember, with the levels of care, you have the, level 1 and 2, and you have the level 3 and 4. So they're kind of clumped together in that grouping.
Hey, Amanda, there's a great question in the chat. I thought we'd just do a call out, take a pause, and let you and Claire weigh in, as I don't frequently involve myself in staffing decisions, but you both do. So what is the recommended best practice in the metro for makeup for the lactation support team expert versus generalist? I'd imagine you'd look at your NICU delivery volume as part of that,
Mm.
but feel free to
Yeah,
comment.
and I feel like, we see the A1 guidelines referenced most often. Let's see. Yeah, there we go. And really focusing on that second paragraph, making sure that we do have the IBCLCs there every day of the week. May not cover every shift, but you would decide on the amount of IBCLCs that you're going to have the FTE for, depending on how many deliveries you do with admissions to your well nursery and your NICU. And Claire, you want to add anything on that one?
Sure. I mean, I think one of the really critical things here in the AAP levels of care document is this operational review and looking at, and asking folks all across your team and listening to parents, like, did they get the lactation support that they needed? And are we balancing the needs in the NICU? I'm a, NICU orient. That's where my clinical expertise is at, but not at a birth hospital. So my perspective is really just listening to you all, but um, it, most hospitals don't seem to have this level of staffing that's recommended by A1 and the USLCA. So when you don't have that, making sure, like Amanda said, that all of your nurses can do the basic support, and that your IBCLCs aren't getting pulled in to help, the multip who knows to ask for lactation and is really there to help with the scenarios where there is an indication for the level of expertise that an IBCLC should have. I hope we're going to cover it a little bit. We have a couple more ideas here, but we'd love to hear from you all in the chat how you've developed your staffing guidelines, what some of your barriers are in your staffing. And if you've looked at some novel ideas about, considering having techs, if you don't have enough, lactation consultants or nurses, making sure your techs are supervised and trained. And then also, are your lactation consultants doing work that someone else could do, like ordering breast pumps or prepping milk for feeds, things like that, that don't need to be done by a clinician?
Well, and even on this slide that you have up, all the birthing facilities are so different in what they're able to provide. But I love how this one even speaks to what are we doing after discharge? So, is that consultant who's the one consultant there for the day also having to, respond to phone calls and try to meet the needs of all those messages that have been left and scheduling appointments. And there's just so much to it, and only so much one person can do. So absolutely, if that's what you have in your facility, what are the other resources that you can use that might not be IBCLCs or designated as the consultant? So
Right. And are your lactation staff the ones who are training everybody else, right?
100%.
That's a piece of an FTE right there, just developing and presenting education, and policy review, policy updating, research.
And if you want to go on to that next slide. So, when it comes to techs, I've heard lactation techs called different things. Sometimes these staff may have another role, like we talked about earlier, and like Claire talked about. But then at times they're pulled to perhaps milk prep, and things of that nature. But I was trying to research this and get some more information on it. I know there are a lot of infant feeding technician programs out there now that focus on safe human milk handling and prep. And so, that might be something that you want to look into. If you have some staff who might be able to flex to this type of position in your role, supporting them to get these certifications, that would be a huge help. And these are standardized educational offerings. And so that would really be something to think about. And they can obviously have other campus or unit specific skills taught so that they can provide some education to patients as they're working with them. But just another idea, is this something that you could have in your facility? All right, next slide. There we go. So what's the role of the consultant? So again, it's going to depend on the staffing that you have in your facility. For Johnny and Jennifer's situation, it feels more special or like there was an exception because there was some infant separation here. But actually, it's a pretty fairly routine. This baby was feeding orally almost from the get-go. So having mom's express milk or human donor milk there. So right off the bat, we're able to give it to this kiddo. But any mother and infant that's separated or a family that's desiring a pump should be supported to do so. So how do you currently use the consultants in your facility to support all of these different dyads and situations? Also, just getting people started pumping. Does that have to be the lactation consultant, or just like Claire said, could that be somebody else already there on the unit? So really taking a look at what are the roles and responsibilities that you have set up for your lactation consultants, and is there opportunity to pare that down and be more collaborative, if you will.
Provider role. Yeah. So, I mean, providers, I think traditionally, at least on the physician end of things, haven't been real involved in lactation. And in fact, when I trained, oh God, many moons ago now, I was, oh yeah, you're that peds intern who looks at everyone's nipples. Yes, that was me. And not anybody else was really interested in lactation at that point in time. Thankfully, I think some of this tide is turning, but I don't think this is really something that most physicians see themselves doing necessarily, right? But we want change. That's why we're all here. We're all here to make things a little bit different. And we do have a role in this change making. In my organization, we always say that all providers lead. And so that is our goal here, is to help you figure out how you can lead in this time of change and what we're wanting to do with all of our hospitals. And, we start with the patient in front of us, right? And what their goals are. We do need to know what their feeding goals are and where they're starting from to help. But then our goal is to really support and protect human milk for human babies, to treat this as a vital resource and not something that is simply okay if it all works out, which is kind of what you heard in our business as usual scenario in the beginning. It's like, well, if everything's fine, sure, then we can do this. No, this is a vital resource. We protect this for children. And so that means supplementing with the appropriate volumes. We've talked about that during the past year. We want to document these things. We want to document adequate feeding volumes, frequency, that we're removing frequently. This not only is important just because, gosh, it's good form. I mean, I think all of us get talked to about documentation from various people in our clinical lives, right? Like higher ups, people in billing, everybody, right? But it's also important for other people on the care team. I mean, Claire and Amanda want to come back behind and look at a note and be like, ugh, she only removed 3 times yesterday. Well, let's see what's going on now. Like, it's actually kind of hard to find any of this sometimes in notes. No, Claire, Amanda, like you have no idea what's going on. Then you walk into a room and you don't know how often they're pumping. You don't know how often they're feeding sometimes. Or you may doubt what's there in the chart, what's listed. And then, we are often kind of called on to write supplementation orders or to go ahead and encourage supplementation, to have that discussion with families. And we want to use an evidence-based tool. We practice evidence-based medicine, right? Using Newt, nothing's better than lots and lots of data points. And Newt provides a way to make a decision that's safe and promotes optimal feeding. And we want to make evidence-based decisions based on type of feeding too. If human milk is available, and WHO has said for decades that human milk donor, if parents' own milk is not available, is the supplement of choice, and that's what we should be offering. That is a conversation for, I think, a lot of us providers who make decisions at an admin level in our hospitals to participate in. We can help with the early initiation depending on your specialty and what side of things you're on. Either encouraging early, as the OB who puts the baby on, or the midwife who puts the baby on for skin to skin, or making sure people know to initiate early, either via pump or hand expression if baby's not able to feed, and then documenting that occurred. Again, it's nice to be able to see what happened if people got that golden hour. And then, it's always safety first in the medical model. So we are usually the people, or we should be the people who first and foremost think about screening for lactation risk factors to make sure this patient doesn't get readmitted due to lactation failure, right? Due to lack of secretary activation. And so I think the other role, besides just supporting, protecting the vital resources, understanding that leading the team in this situation isn't just the doing, but it's actually making the culture change happen. And this is super uncomfortable, right? Like this is not just business as usual. This is something very different for all of us. So we have to have cross-specialty convos. That means asking for pediatricians. It means asking, mothers if they had breast change during pregnancy. And I think this gives a lot of my colleagues a bit of the vapors. It's like, oh, I've got to talk to the adult about their body. This is very uncomfortable. I like small people. Yes, I also prefer small people and a pediatrician. But I also like to get them their milk. So I had this conversation with their parent. And it's important to prevent readmission. It's important to know what those risks are. That's our job. So we have to normalize having some of these conversations. OBs might need to get used to asking how often baby is feeding, how often are you pumping, and making sure that parents understand that whole process physiologically and having a conversation about feeding as opposed to how's breastfeeding going? Are things fine? Let's talk about your bleeding, which is, I feel like sometimes how postpartum rounds kind of go. And then, we can facilitate care by stretching our skill set. It's not rocket science. And I tell this to all of the residents I teach and to all of my colleagues, and they ask, and pretty much anybody who'll listen, that it's really not that hard to assess a feeding. You may not be a lactation consultant yet. I like to convert and have people get their IBCLCs too. Grow your own. I think it's a great idea. It's intellectual homesteading, right? But, I'll tell anybody who'll listen that it's not that hard. It's some combination of mouth and breast, and you put the kid on and you help out and you see if everyone's comfortable and if you've got some sounds that you hear. Come on, it's not hard. And the more you do, the more you learn. Get a little hands-on. Let's learn from our nurse colleagues. Doing some of these things, setting up a pump, figuring out how to put some pieces, some plastic together, showing to people turning it on. This is not hard, but when we're working on culture change and we don't have the staffing for that one specialty that has lactation in its title to come in and do it all, us leading at the bedside and doing some of these things, they'll notice when we change what we do, so does everybody else. Next slide. And then once we get change going, it's not time to abdicate and say, all right, you guys got it now, fine. I'm just gonna head back to my very comfortable medical problem list. No, we have to teach, and this is often what I've seen happen in 18 years of lactation is that we get like a certain cadre of providers kind of invested and interested. And then, people get very tired and very burned out, and we don't have that next generation of people onboarding, learning, and continuing that change. We see one do one, teach one, right? And we have to model that for the next set of providers. So we have to change our onboarding. We onboard a new provider, a new rounder. It's not just like, oh, we work on breastfeeding here. It's like, no, let me take you around and show you what we do differently here with breastfeeding. Let me show you what our role is. Let me socialize you into what we do here, because it's probably going to be different than what you've done. It's the only way to keep change going. And we have so little fundament in medical training with lactation. I can't emphasize this enough. Most people get 1 or 2 hours of lecture in pediatrics residency, and then are out there in the world without a whole lot of other info. So us teaching and propagating this with incoming staff, especially trainees, is vital. Yeah, and then I would be remiss if I didn't mention EPIC. We have lots of breastfeeding physician-specific CME, and then we've got the Academy of Breastfeeding Medicine protocols, which are evidence-based and have lots of great practical clinical point of care guidance. So check those out. Next slide. So let's go through and talk about what we might do, right? Like, what's a best case scenario? How can I make this not so great, but super typical scenario? These are all the cases I ever present. These are always based off my own patients. So this is fairly true, not the same diagnosis for patient privacy, but a very similar situation with one of my own patients. So how could this be better? What could we do? So, we've got this baby with a CCAM who gets admitted, mom with gestational hypertension. She has a neo consult, and they tell her, yeah, either way, no matter how everything shakes out with Johnny, what we want is the milk. And to get that milk, if Johnny isn't doing well, we want you to go ahead and hand express or pump right away. And then, of course, the flurry of questions starts up, because this is why doctors don't say these things and don't encourage more conversations, because people ask us other questions and we need to get back downstairs to the unit, right? About, well, what about hand expression and where do I get a pump? Doctor pulls out a QR code and says, why don't you check out this video? It's got some great information. Mom opens it on her phone. And if you need a pump, the nurses and the techs will get you a pump. And then Jennifer says, well, I'm just waiting here anyway. I guess I'll check this out. So we go through our labor delivery course, and she's getting induced after so long in the hospital. And, she's got her epidural in place. She's making some progress. And the nurse asks her about her feeding plan. And she says, yeah, I want to breastfeed. I've been, before they started the pit, at least I was hand expressing and practicing. I was figuring some things out. And nurse says, yeah, if baby can't feed right away, we can have you hand express, and dad can help too. As he watched the videos. Next slide. So of course, our best case scenario still involves things that probably nobody was really wanting to have happen, because that's life. We've got our D cells and fetal intolerance to labor with increasing Pitocin doses. Not a great situation. C-section, a baby who maybe wasn't exactly ready to come on out and is getting taken to NICU. So she gets her kiss and a quick cuddle before heading off to NICU. And the NICU nurse who is transporting turns to the nurse in the room and says, make sure she gets a pump in recovery. Next slide. So, it's not easy. This is still not a great situation for Jennifer, and she's shaky and feels terrible in recovery, but dad started hand expression so she could just rest a bit. She starts her mag, which is torturous and awful, but it's nice to keep your brain intact, I suppose, right? She felt terrible, and the pump arrived. A tech set it up for her and showed dad how to help her pump. When she finally gets up to mother baby from recovery, the admitting nurse asks her about pumping hand expression, what she's been able to do since delivery, praised all of her efforts, and explained how to get milk to baby and how often she should pump her hand express now that baby's staying in the NICU for a little longer. Postpartum day 2 was a wee bit better. She's pumping every 3 or 4 hours. She still feels terrible, but meh. She finally got wheeled to the NICU around 18 hours post-delivery, and dad took the pump kit with her because the mother baby nurse said, well, maybe you can pump down there. Sometimes that they encourage that. So why don't you go ahead and take her pump kit with you? Let's go. NICU nurse saw them coming, grabbed some screens, helped mom do some kangaroo care. Fortunately, couldn't do much more than pump at the bedside, but she got to leave that fresh milk for the next feeding, which made her feel great. And before they left, the NICU nurse reviewed again how to get the milk to them for the feedings and encouraged her to come back down and pump at the bedside anytime she wanted. Next slide. So, Johnny's still a little pisher, he's admitted, he's observed, his chest x-ray didn't look too bad, as it sometimes does with these CPAM-CCAMs. It looked fine, but, tick, so he stayed monitored. But when they started to feed him, they went ahead and bridged him on donor milk, which Jennifer felt great about, felt like that was supporting her goals. And she felt great he didn't have to get formula just because she didn't have anything ready for him and couldn't feed him. He took a nice 10 cc first feeding paste, and then, seemed kind of eager the next go around and did spit up the 15 cc's he managed to guzzle. But, stayed with his human milk and seemed to tolerate it fine. No one diagnosed or said he had a feeding intolerance. That's for sure. And he had some kangaroo care with mom because, of course, as these things go, even in the best case scenario, he still decided to be tachypnic, and the nurse wasn't quite ready to feed him when she came downstairs, but he did get some nice skin to skin time. IBCLC reviewed the chart and made plans to see them the next day. And for a discharge, Jennifer's much improved, especially now that mag's all out of her system. She's on her labetalol and morphine, pumping, hand expressing, getting 20 cc's pretty often now. But Johnny's also latching too. IBCLC saw them in the NICU and got 2 good direct feeds in. The mother baby nurse reminded her when she did her discharge with her that her meds were fine with nursing, but she was already pretty confident about that because Johnny was getting the milk already, that it was going to be fine. And then the discharge RN reminded her that she's going to need some close lactation follow-up because of the early separation, and to make sure that she arranged that, asked for resources at her pediatrician's visit or from the lactation consultants at the hospital. Next slide. So, not too much different here. Johnny still has the same CPAM and needs his referrals, but he did get to see the lactation in the hospital, latched really well in day like 3, like I said, and 2 good direct feeds, but otherwise was bottling around an ounce at the time of discharge. The NICU discharge RN and IBCLC both recommended close PD follow-up and lactation support after discharge. And importantly, our discharge provider sat down and said, yep, we need these referrals. These are kind of quirky, and there's a lot of shared decision-making about how to treat, but this type is usually fine. But you do need to go see some specialists for him. And let's talk about his feeding, his weight, his NEWT is 50th percentile. He looks pretty good. He hasn't lost too much weight, and that's what he has lost is normal. But we do want him to feed direct at least 8 times in 24 hours. And if he's not direct feeding well, go ahead and pump and bottle him with a slow flow nipple. And here's a QR code to check out some paced feedings that the nurses have been doing here in the NICU with him. Discharge provider also reinforced that she needed to see the PD within a day or 2 of discharge and to work with lactation post-discharge. So our root cause analysis here. Well, I mean, this is still not an easy situation. This is not the super straightforward, healthy, easy delivery with no complications and relatively little iatrogenesis or separation, right? But we made sure she knew that the milk was important and support was provided for her to do so, and education at a critical time when she could actually pay attention and learn and make those next steps. She got an early start and she removed frequently. That was important here. And there was a system in place to ferry the milk and mom to NICU, both. We involved partner. They're just sitting around there anyway. And then we had some culture and resources in the NICU. They were ready to support her when she came in to do that kangaroo care, to do that bedside pumping, to support this dyad. And then importantly, again, my bias as an outpatient doc, there was discharge planning that was specific to breastfeeding because, guys, we so appreciate what you do in the hospital, but there is so much else that happens once they leave. And when I see them at 2 weeks or 3 weeks, there's a lot less that I can do than when I see them at 4 or 5 days. Next slide. Good.
So, the getting the FTEs and, hiring the staff and all that definitely takes time. So what's something you could do now? Where could you start? How could you evaluate the data, for instance, that you're getting every month? Where can you take that other than just a leadership group? If you don't already have a multidisciplinary team that's meeting, if you don't already have a task force or a committee, that would be a great place to start. And looking at how human milk, what's the education that's available in your facility? What resources do we have? I just saw a question in the chat about the QR codes and the videos and things like that. Those are things that a multidisciplinary committee could look at. What resources do we have for the families? What does our data look like and where are we going? And who could be on that committee? It could definitely be excited staff, advocates. It could be the different departments represented. You could have providers, you could have families. What could that look like in your facility? There are some resources to look at, some great articles that are out there. And I don't know, Claire had mentioned a few to me. Maybe she could pop those in there to the chat. But when you're thinking about multidisciplinary teams from a breastfeeding standpoint, I would just wanted to share what my facility does. We have a multidisciplinary team that I facilitate. So as a nurse facilitating this, it's not led by lactation. We partner with lactation. So it really gives a voice to all the staff. It gives everyone a chance to bring forward what you're seeing on the units. And that's what we always start with. What is happening in your units? Tell us about it. And we do have leadership present. We have managers involved. You have clinicians and educators involved. So it allows us to see, is the education we're providing getting to our staff and therefore getting to the families? And then how is that actually happening? How is it actually getting to the bedside? Some great ideas have come out of our collaboratives, looking at some of the team members have been to conferences and heard these great ideas. Well, this is a platform for them to come back and talk about it. So, if that's something that you could see starting or joining or improving at your facility, really evaluating what's your mission and what are your goals so that you can make that 30 minutes or that hour, very efficient, and really thinking about, are there some subcommittees or some opportunities for things we could start? And then if there's the option, looking at your policies. Could this group take a look at your policy, your task force? Could they take a look at your policies and maybe make some impact there and make some changes there? So just to go back to that question really quick about the QR codes, I know for us at our facilities, we really love the First Droplet website. I have it pulled up now, and I mean, I love it every time I pull it up because you have a lot of good resources for antepartum, preparing for the hospital. You have things for the couplet dyad that obviously stays together, and then you have some resources for those where there's maternal infant separation, and you also have the resources for the Spanish population here on this website. So that's what we use.
Thanks, Amanda. And I heard Dr. Morton say they added some new materials to First Droplets website. So it's easy to make a QR code or to use those links. QR codes have gotten to be really popular. So work with your hospital communications or education department about how you want to share that. And those of you who are doing that now, if you want to share in the chat, and I know I'll hand it back to Dr. Fairley, I'm kind of interrupting, but to kind of share some of how you're doing some of this work already.
Yeah, we just got a request to drop a link to First Droplets in the chat, and I think that's well advised. Let's go ahead and drop that, Claire, if you want. But I do think we might have a role for putting together a little bit more of a formal QR heavy resource kit, something short and sweet to carry around on a clipboard, perhaps. Do people still use clipboards? Maybe we can just attach it to the computer if that's what we do now. Every hospital's a little different. But feel free to drop some notes in the chat too about what's going well in your unit, what isn't going well, how much these cases resonated with you, and if this is something, what you think your big barriers are to getting to a best case scenario like this. I'd like to think we're not nearly as far as we once were from getting to this best case scenario here in Georgia. It's a QR party. Yes, thank you.
And it's just firstdroplets.com. I can't get in the chat while I'm sharing the screen, but if Amanda or someone can just put that in, but it's, she covers the ABCs of delivery. So the ABC.
Thank you, Dr. Rose.
Yes,
Yeah.
thank you.
Yes.
And I know at CHOA, at some of the pumps just have the QR codes right hanging on the pump trolley, which is a great place to put it, up on the bulletin board or the whiteboard in your delivery, in your labor and delivery rooms. There's lots of options of where to have it on a badge card.
And Claire,
it is something to talk about. Oh, sorry. I was just going to say it is something to talk about with OB, right? This is the case we ran our best case scenario by some OB colleagues to talk about, whether or not you'd want to be hand expressing while on Pitocin. And there's some definite discussion. Obviously, it needs to be had for people on L&D delivery. L&D, that's not really a pediatric space just yet, momentarily before we take the baby off and get you off to mother baby. It is, but it's definitely a multidisciplinary conversation. But I do think people are eminently more teachable in that moment, and some hand expression surely at some point when labor is imminent sounds like a fine idea to me, but I defer to OB opinions. Amanda, you were saying something?
I was just going to say we had the QR codes on a sticker that we put on just a simple cup with spoons, individually wrapped spoons in it. And that way, watch the video and here you go ahead and start practicing. So that's on the bedside on a mission.
That's great. And I think L&D is kind of the last frontier of getting some of this information in on the early end, but it's a great opportunity to have to partner, for OB and NICU to partner to get some of this work done, especially for the more high risk dyads. But anyway, I think we're getting very close to the end of our hour, and I do want to leave time if there's any questions. So our big take-home points here is that our status quo and is not getting the job done for our families, right? People are not meeting their goals, and that perceived failure is terrible for a lot of families to live with and directly impacts feeding for subsequent children, for primaps especially. So there's a lot of collateral damage when people don't meet their goals, and our status quo is not hacking it. Lactation care is everyone's job because it is such a fundamental part of the postpartum experience, of that post-delivery experience. And it's really hard to make changes. Let's not underestimate it. Like, who else hates this decade? Like, I am not a fan of this decade. Okay. There's been a lot of change, cultural change, societal change, and it is hard and it is uncomfortable. And here we are making even more changes, even more inroads. So it's tough. And I think we all have to kind of, especially as leaders, providers as leaders, and administrative leaders, we have to understand that it's a top-down process that's hard and requires a lot of hands-on management. But these families benefit enormously, even from little changes, even just someone saying, hey, let's talk about hand expressions. So in case things don't go right, let's have a birth plan for breastfeeding. In case we need one, let's get this info in. And some of these small changes make huge impacts on families. So the change is hard, but it's worth it. Thanks. This is my youngest. Just in case
She's
people,
so cute.
in case people think it's a stock baby, I just, credit. That's my work.
And here is a little bit more of our work. Next month, we're going to be hearing from Dr. Julie Ware, one of the authors of this really interesting recent paper published on associations between breastfeeding and postparinatal infant death, kind of to undergird just the reason for our work and why this work is important. We also want to invite you to our upcoming EPIC webinar. Our breastfeeding webinar in August, Breastfeeding Month, is presented in partnership with the Georgia Breastfeeding Coalition. And we're going to have a panel including a pediatrician, a representative from the Department of Labor, Wage and Hour Division, and Jessica, I think, is here on the call today, who's an IBCLC and a nurse practitioner and our current president of the Breastfeeding Coalition, and Dr. Nandi Marshall from Georgia Southern School of Public Health on how to support working parents and how to get caught up on all the big changes in laws around lactation accommodation, and really what our role as healthcare providers and those working with new families is, both in leading the way as leaders in healthcare institutions and employers, but also in making sure our patients are aware of their rights. We do have some micro lessons updated. You should check it out. We have 10 micro lessons up now, including a new one on PDSA cycles. So check that out on the Train website. And I'm going to stop presenting. I did put a link at the very top of the chat that I will paste again on the webinar, the EPIC webinar. So let me put that here again if you want to register. Let me try and make sure I got that here. Okay. Thanks again for all of your attention, and especially to Dr. Fairley and to Amanda. And we appreciate Dr. Pulliam of Covenant Care Pediatrics. He also is affiliated with Piedmont Henry, who is a member of the collaborative, who wasn't able to present today, but we appreciate his willingness to help if he was able to.
Thank you, Claire. Thank you, Dr. Fairley. Thank you, Amanda, again, for everything in presenting. Claire already did a couple of date reminders, but I also did want to add that if you have not already submitted your SMART aims and driver diagram, if you could please do so. She mentioned the September webinar already, but our August audit will be sent out August 21st, and then our September audit will be sent out September 25th. As always with these monthly webinars, we do ask that you use the QR code to register your attendance. If for whatever reason the QR code does not work, I am putting the link in our chat for you as well. We ran a little bit over, but thank you all. I hope everyone has a great day.